Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Welcome back to another episode. I'm your host for today. My name is Raquel Maris. I'm an occupational therapist and a project coordinator at European School of Lifestyle Oncology. Today's guest is Adrian Pogacian, a licensed clinical psychologist with executive training in psycho-oncology and a background in global health diplomacy. He's the founder of the INCA Psycho-Oncology Center and a leading voice in the field, known for his work on coping with cancer, family dynamics, and post-traumatic growth. Adrian also lectures internationally, contributes as a journalist, and plays an active role in organizations such as the International Psycho-Oncology Society and MASC. Adrian, welcome to the podcast. It's a pleasure to have you.
Thank you very much, and thank you for having me today. It is a great pleasure.
Let's start from the beginning. What first drew you to psycho-oncology? Was there a particular experience or moment that led you in this direction?
Usually, people dealing in the field of psycho-oncology have, let's say, the background of having this disease. I didn't have this disease. I had and have other disease, but it was a nutrition oncologist that helped me a lot in recovering myself, and she know that I graduated psychology, and she always asked me about the psycho-emotional feelings or part of the persons, and she asked me this because all her patients asked for someone to go to talk to, and it was just after I graduated psychology, and I say, why not? I started do the research in, I guess it was 2020. It wasn't very much at that time in Europe, not so much. And I said, okay, knowing the disease, it will be, I don't want to say it, but I have to say it, it will be a field of the future, because the number of cases it's increasing, and I learned that the path to success is indicated by gratitude, and if I can give something back to my community, it will be a pleasure and an honor, to a community where I for myself, where I learn, where I have my family. So this was the reason that took me to this field of interest at first, then the field of practice, because I'm practicing now, and also a little bit of research, but maybe we'll talk about what is research in Eastern Europe a little bit later, because it's another way of subject. But first I entered in contact with psycho-oncology, I guess it was 2019. It was in Hungary. I was to a hospital there with my father-in-law, and I saw a department called Psycho-Oncology, and I was so shocked, and I asked someone from the hospital what that means, and they said that they are the psychologists trained in working with cancer patients, and from 2019 it seems a very interesting idea. And then it was my case in 2020, and then this is the road till now.
Thank you for sharing your story. I would like you to clarify a bit more. What is psycho-oncology? You've said it shortly right now. It's a psychologist working in the oncology field, but what exactly is it? What exactly is your role in the integrative cancer care?
Here I want to make two, let's say, clarifications. First, when we are talking about psycho-oncology, it is very important uh, the let's say the big field of research. What I mean by this, for example, in the United States and Canada, psycho-oncology is a subdomain of oncology. But in Europe, psycho-oncology evolved as a subdomain of psychology. And sometimes with our colleagues from US or Canada or Australia, we can't understand each other. Why? Because the background of us is totally different. Okay, there's the first one. The second one is about the notion. It's psycho-oncology and it's psychosocial oncology. It is a major difference between those two notions. And I try to make it as simple as possible for audience, not in complicated terms. Psycho-oncology means the psycho-emotional dimension of the patient, what he feels in terms of anxiety, depressions, disorders, etc. Yes, in his fighting with cancer. Psycho-oncology, it's he or she is the patient into or within the community. So psycho-oncology, it refers to the part within the patient. Psychosocial oncology is the patient within society, where are another things like financial toxicity, back to work, yes, like occupational therapy, and so on. So this is, let's say, in short, the definitions. The definition is more complex, and it depends from which angle do you want to talk about. It is a definition that as a basis remains the same, but sometimes the outcome might look different. But it is important to know that psycho-oncology depends or deals with the emotions of the cancer patients related or associated with his or she fighting with the disease. All the, let's say, personal history of or the personal journey within this struggle.
Thank you for making that clear. And it's also clear that it's a vital area, and yet access to psycho-oncology support is still far from universal. In your view, what gaps still remain, and why do they matter?
Psycho-oncology as a field, it's quite a new one. And this year we celebrated the first year of Psycho-Oncology Day. And the founder of Psycho-Oncology was the Dr. Jimmy Holland. And at the end of the the 70s, beginning of the 80s, she was for the first time the person who was thinking what might a cancer patient think, feel, or what are the unmet needs of a cancer patient. Yeah, and 40 years ago, after, we are still, as you mentioned, finding some gaps. There are many reasons. I'm thinking how to put it in a logical order. First one, it's for example in 1984, yes, when it's like the title of George Orwell book 1984, the IPOS that you mentioned, International Psycho-Oncology Society, was formed. If we are looking in the Eastern Europe, yes, it was the first time when the states begin their road to liberty and freedom. Yes, so we have in West the first idea of psycho-oncology, but we have in East the communist area. Okay, 4 decades later, we share the same horizon of wisdom, yes, but the quality and the quantity are not the same. That's the first gap. The second gap, it's, as I mentioned before, um, within our field of psychology in Eastern Europe, we are trained during the faculty to work directly with the patient. And I think you are the same. In United States, Canada, Australia, there are 2 or 3 different types of psychologists. And majority of them are in the research part. So they are not in contact with the patient. Yes. So we see studies, and some of them we can apply, some of them we can't apply. Why? Because if you are not working with the patient, it's very difficult to make a study that it's general apply. Okay, that's another gap. But the most important one now, and if we are looking to the US today, it's money. It's the financial, it's called in our field the financial toxicity. Yes. You mentioned about coping. This is my favorite or my beloved field of expertise within Psycho-Oncology. Coping with cancer. And coping with cancer, starts when the resources needs to overcome cancer disease, yes, the resources that you have. So this, to translate this to your questions, is the same thing. So when the needs to apply, to implement psycho-oncology as a field within a country overcome the resources, we have a problem. And what is happening nowadays in the United States with a lot of money cut from research, this is another gap. If we are looking in Europe it's not only about the money. In Europe we have another gap of cultural background, of people that they don't know when to go, why to go. As a specialist, I have to answer to a questions why to come to see you. They don't understand why I have to come to see you. I made some campaigns in Romania of screening for cervical cancer, for breast cancer. None come. Yes, none, or almost none. Yeah, like 10-20%, it's none. Okay, to a national level campaign. And why? Because they are thinking in this way. I know I'm healthy. Yes, till I'm not going to the doctor, I think I'm healthy. Okay, if I'm doing to do a free, I repeat, a free screening, I'm healthy. Okay, when I'm going to do a free screening, it's half-half. It's 50-50. Or I have something, or I'm healthy. Okay, the problem interferes when I'm not healthy, when I discover that I have something. And then what happens? I'm in shock, the fear starts, I'm in panic, etc. And every stage of that emotional part, you have to pay it. So more or less, you have to pay for your emotions. And people don't want this. And this is the major gap in applying psycho-oncology within at least my country, but more or less in Eastern Europe, where is this cultural background, the lack of cultural background, the lack of not going to check yourself annually, the lack of psychoeducation. And I'm very shocked, and I'm not exaggerating when I say it's very shocked, because I have a lot of patients, under 25, with many different types of cancer, and 80% of them due to lack of psychoeducation. I thought it was, I only thought. And then it happened, but I didn't talk with my parents. I didn't talk with anyone. So you are my only hope. So we are like in between the two extremes. nobody come to us, why should I come? And then you are my only hope. And in these extremes, how can we build something to be to stay in time, or to build something that the next generation build after us, and so on and so forth.
Yeah, it's truly important to address it for sure. And as you mentioned, one of the gaps, it's also related to workforce development, right? How do you think we can train more professionals in this area? And you've said it also before, it is urgent. So why is it urgent right now?
Um, I'm also in Romania a lecturer, because in Romania, according to the Romanian laws, every psychologist or nurse or doctor or etc., healthcare professional, to put it this way, have to do an executive education course of 3 months to become psycho-oncologist, or not psycho-oncologist by definition, but the diploma to have the accessibility and the recognition to work with cancer patients. Okay. Um, the first conclusion after, I guess, 4 or 5 series of students, let's call them students, more are older than me, and I am not so young, is that came psycho-oncologists or doctors older than me. That means plus 45. Why? Because they faced cancer before. They want to help. They are part of the healthcare system. The youngest, or the adolescents and young adults, yes, 21, 22, after the graduation of psychology, they don't come because they don't know what it's about. They don't understand the fact, and this is important to understand for a psycho-oncologist, that a cancer patient have different needs that, let's say, not a normal patient, but a patient that we see it as a psychologist. Yes. For example, the cancer patients don't have time to complete questionnaires, and questionnaires are our main instruments in providing the outcome. Yes. Okay. Cancer patients doesn't have time. This is a fact. Everyone's know. And we as psycho-oncologists today, we have, and I feel that we have this pressure of deliver outcome in a minimal time. So we don't have the time that we had before to give an outcome for each cancer patient. And here maybe we'll talk about the artificial intelligence instruments that maybe or maybe not will help us or not. So they have different needs. They don't have time. And when you don't have time, you can't apply the classical cliche in talking with patients. And then the new generation doesn't want this. Because working with cancer patients means that you can work once with more than 5 or 6 each week. That means one a day, because cancer means caregiver, which means that you don't work only with the cancer patient, you work also with his or her caregiver, which is his mom, dad, I don't know, child, parent, etc. This is another story. So from the starting point, you work with 2 persons, more or less. So if you want each day you work only with 1 person, the money that you gain is not enough, maybe for some of us. Yes, psycho-oncology means that you are more or less implied in their life story, especially when it's the end of life, especially then. And more or less you left your mark on there, and this is not an easy thing, and which is a fact that I want to share with you and with the audience. I always knew that it will come a time, and I talked with my wife because together we founded Inca Psycho-Oncology Center from our money for the community. And I always knew that it will come a day that I will be affected by a dying patient. But the paradox was that I was affected by a dying cancer patient that wasn't mine, because I knew that patient. And she was very young. She was only 30. And in 1 year, she was gone. And that was so, I can say, hurting for me as a specialist. And also my wife asking me all the time, why are you so affected? And I guess I look back to all my patients. I never lose a patient till now, which is which is a good thing. But I look back at all the cases, all the persons, and then I realized that we, as psycho-oncologists, with every case, we are starting from zero. With every case, we are on the starting point, because each case, each patient is a new challenge. It's like Nietzsche said, it's not the circle of recurrence, but it's the circles of starting again in the new day. And it's like the Sisyphus, but as Albert Camus pointed out very nicely, we see Sisyphus happy, you know. So we see also happiness or joyful in doing this. Patient by patient, the same story. The new generation, they don't have this patience. Yes, they want. I understand them. Yes, you are new in the field. I was like them. You want to do a lot of things. You want to leave your fingerprint there. Yes, but it's like like writing in the sand when the wave came, and they want to do many things, and but nothing on the same time. And psycho-oncology is not a field for persons that are not, let's say, heartily imply, more or less. And this, it comes with age, it comes with a professional maturity, this comes with an intentions, this comes with a life experience, and so on. I guess I respond to your question.
Yes, for sure. And I completely agree with your words. Thank you for sharing them. You mentioned digital tools and support, and I wanted to elaborate a bit on that since we've seen a huge rise on digital health, online support tools. What innovations do you see as promising in the field of psycho-oncology?
Um, from the starting point of these discussions or of the area with digital or all what is digital, I want with this occasion also to ask the audience, especially the patients, the young generations, to pay attention to the information that are on the social media. Please double check the information. Please double check the sources, because there are two kinds of informations. There are misinformation and disinformation. The difference is the intention. Misinformation is an information that wants to be correctly, but in the context you use it incorrectly. Yes, this is misinformation. Disinformation, it's an information that directly it's intended to be incorrectly. So we have to stop thinking. And if you are looking, or the audience is looking to the latest ASCO meeting that ended nowadays, they will see a manifest of the ASCO board, to the social media leaders, asking for a very attentive approach to information on their social medias platform, because 30% decrease the patient's treatments due to so-called alternative treatments. So drinking a tea doesn't mean you get cured. Okay, so this was I took this opportunity to share again and again the importance of reliability, yes, the sources of the information. Now, to answer to your questions more exactly, digital tools are helping us and not helping us. Why I'm saying this, and I will elaborate. I guess we have time to elaborate a little bit. There are also, again, two things, two sides of the story. The first one is, let's say, from psychologist's point of view, from my point of view, and the other one is from the patient. But at the end, the conclusion is the same: is the human touch. Psycho-Oncology means human touch. That's a statement. Even though it's not physical, is the idea of human touch. Psycho-Oncology can be do 100% on, let's say, digital platform, or like we are talking now, virtually. To be very effective as psycho-oncologist, you have to have the patient in front of you, because he or she have to feel that the place is safe, is secure. They don't talk. And another paradox in psycho-oncology is that silence is the most important way of communication. And when you learn when to be silent, that means that you are a good psycho-oncologist. So to come back to digital tools, what help us as instruments? It will help us. Now I will speak broadly about this. We can talk about artificial intelligence instruments or digital or telehealth or whatever when we are talking about an amount of patients, yes, like MSK in the United States, 1 million patients. Yes, we can talk there about AI instruments or thousands of patients. Why? Because I'm a psychologist or psycho-oncologist. I see a patient for the first time. Yes, I lose in Romania between 2 and 4 sessions finding out what the patient needs, to find out if anxiety or depression is dominant, if he or she has a disorder or doesn't have a disorder, if he or she had suicidal tentative or not, and so on. And there are instruments that are measuring this. And if the patient will come to me, yes, at my INCA center, for example, with a paper where I will have all this information for the first time when I see him or her, it will help us a lot, because it will be like a file saying that he's anxious or depression, yes, with no medical history, this, and I can start directly the strategy. Maybe not the best strategy, but with copying flexibility, we can adjust that in time. So I don't lose 2, 3, 4 sessions in finding out, in guessing what it could be. So this is the field where, from my point of view, in my opinion, it is the most important to have this help from digital sources. From the patient side now, it is, if I'm not mistaken, a pilot study in Netherlands, I guess I say it correctly because they changed the name now. I put in Netherlands or Holland, and it was like a digital twin. I don't know if you know the idea of digital twin. This is used in radiotherapy, but they made the same idea in Psycho-Oncology. What means that? That means that when you are working with a patient in a hospital, you see it every day, yes? When the patient is doing chemo, radiotherapy, or immunotherapy, okay. But there are moments when, as a specialist like me, you have to go to a congress, you have an exam with the students, you can't be there. So they created this digital twin, like a remote control, and appear a hologram. Record it with what you want to hear for the next session of chemotherapy, for tomorrow, let's say. And it is the specialist voice, and the patient just press, I don't know, I want a motivational one, or I want to be encouraged to do, to not skip the tomorrow chemo. And it is my voice going. But this is for the short-term effect. And then, as I mentioned, this works once or twice. Otherwise, you have to go back because the patient needs you, needs that human touch. So when we arrive at these things, we can think or move forwards. I'm talking now from a part of Europe where I told you before, yes, in '89 we had the revolutions. I'm not talking what is happening in the west part, which is more developed. I'm talking about Romania in the eastern part. This is what I would like to happen in the nearest future. I'm hoping, but I'm not sure that I will reach to use them, but I hope.
Let's hope together. And I loved the statement that you made that psycho-oncology means human touch. And mostly every intervention in cancer care, it depends on human touch too. We will have another episode explaining human touch regarding nursing and its meaning, and it's so powerful. We are always touching some of the same points, even if it's in psychology, if it's in nursing, or if it's in other areas working in the oncology care. But there are some points that they are global, right? So when we talk about cancer care, we have to talk about human touch. We have to talk about communication. And right now, regarding communication, I wanted to explore the patient experience, especially regarding cancer diagnosis. What are some of the most common psychological responses to cancer diagnosis, especially in those first days or weeks?
You mean the questions that patients ask us or what the patient feels?
Well, mostly what they ask, and how can we address them?
Okay, so the first questions of every oncological patient is why me? Maybe you heard this question before. This is the, let's say, the, like in mythology, is the why me question. For these why me questions, there is no answer. It is a philosophical one. We can't say why me exactly. That's, let's say, philosophical one. Yes. But as Dr. Alberto Costa pointed out very nicely, you can't be a good oncologist if you can't handle the why me question. And I say the same to psycho-oncology. You can't be a good psycho-oncologist if you can't handle the why me question. Because the cancer patients don't ask us and wait for concrete answer. They ask us to handle their pain, their healing. They wait for us to be with them during the process. And I have this, not theory, because it is Marcel theory, but when I'm talking with the patients for the first time, I'm always looking on the last 24 hours. What makes that? And I guess this was your questions. It is pre-diagnosis, diagnosis, post-diagnosis. It's like 24 hours. Yes, it's like a day. We spend our life as we want, then is the shock of diagnosis, then it's the new reality. This is very simple. Now, to explain a little bit the context, yes. Another statement or fact is that every patient know or feel the diagnosis. There are very rare the cases when a patient said, oh, I didn't expect this. No, more or less they know, they feel, because cancer is, let's say, it's not a disease that you are going and like a pharmacy, you know, and they give you a medicine. First they say you might have, you are in this, but we have to check. So at least they are saying this to you. Yes, we have to check, we have to do analysis, we have. So you already feel it might happen. Okay. Then comes the diagnosis. Of course, the diagnosis comes with shock. This is the shock. That's the first reaction. Shock and fear. Fear is the first emotion, shock is the first reaction. And then comes all our fight as psycho-oncologists, the post-diagnosis phase. To learn the patients live in a new reality. And here are two important things that, let's say, are answer to almost, I can say, to all the questions. First, we have to learn them two things. That first, to transform their defensive mechanism, because when you are in a shock, in fear, you build walls, yeah, because you have fear, you feel it. So in our field, it's called defensive mechanism. Defensive mechanisms are a good way to live for 24 hours or 48 hours. Then this defensive mechanism should transform with our help in coping mechanism. Well, then it depends. It's emotion focused coping or problem focused coping, and it's another story. But this is the first thing, to transform the defensive mechanism in coping mechanism. The second one, and now I'm addressing to the specialist. This is a lesson that I learned on my own. We are not there to solve problem. It is a thin line for us as specialists to enter in problem solving. Even though in the first day the patient wants for us to solve their problem, we can't do this. That's not our job. Because doing this, we will not arrive anywhere. So we all the time have to challenge the patient, motivate the patients to move forward. But there is this trap of, or this thin line of entering the problem solving, because they try everything after the diagnosis. The why me questions, this is for patients, yes? But if we are talking about pediatric cancer, the patient comes to us and say, what this means for my family, what this means for us now. And we have to be sincere, we have to be honest, and to say, really, I don't know. I wish I knew what to say to you. Sincerity, honestly, are the fundamentals way in this field of psycho-oncology. These are the fundamental issues of the basis of communications with cancer patients. This is the reason that I say that sometimes silence is the best way to communicate with a cancer patient. but you have to know when to make silence. Yes, because as the French philosopher Jean-Paul Sartre pointed out, that every word has consequences, every silence too. Yes, it's true. Every silence has consequences also, but we have to know when to be silent. And just to say honest, I wish I can give an answer to this or to that. I'm not in your position, but I'm trying to. Patients have to see that you care. They don't need concrete answers because they know more or less the disease. But we have to use communications as a tool to share with them the fact that we care about them, because at the end this is communication. No, it's a two-way, that we care about. Yes, that they can trust us as professionals, as human beings, because if there is no trust, we can't move forward. So in the first 24 hours or 48 hours, all the answers to the questions of the patient should be around the issues of trust. Building trust, this is the first process. You have to handle the why me, why my child, why my parent, and to let patients express their emotion, because there are two, let's say, two things that we don't want as a psycho-oncologist. First is for the patients to repress their emotions. We don't want this, because repressing your emotions is the worst things that can happen for any one of us. The second one is not transforming this defense mechanism that I mentioned before in coping mechanism, and it's very dangerous when we are dealing with the patients that defensive mechanism is its or her behavior. Defensive mechanism never should become a behavior, because if defensive mechanism becomes a behavior, there is no progress, because the word is self-defensive, means no progress. I hope I answered to your question.
Yes, and thank you for clarifying some of the coping mechanisms that patients show. And thinking about the wider relational impact, we know that cancer diagnosis doesn't just affect the one person, as you were saying. We have mentioned before, it transforms entire family systems. So, regarding family dynamics, what are some of the common challenges that couples and family face? And also, if you could clarify a little bit about how to communicate with children and teenagers regarding a cancer diagnosis, either in themselves or in a family member.
Okay, I will try to answer to both of them. I'm working now to an interesting case. It is really interesting because there is a young boy of 6 years old that is doing chemotherapy, but he has not cancer. It is a strange situation. I have not don't have here the notes, but the medical specialists, they know it is a syndrome that the boy has, and this is the procedures. Even though that he has not cancer, he's doing chemo, and then he will do radiotherapy. But from me as specialist, the procedure is the same. And her mother came to me with what you asked me, what this will happen, what this means for our family, because she wanted to know not what to feel, but she wanted to know how to be a caregiver, because here we are talking about caregivers. it's a thing, coping mechanism or coping in general and caregivers are maybe easy terms to use, but it's not so easy. It is very difficult for each parent to understand that it's not only a parent, it is a caregiver. You are a parent and you are a caregiver, and now I'm in the process of learning the mother how to deal with being a caregiver. Okay, so now to answer to your questions, first thing is that new reality changed the structure of the family. That means the mother is more or less the caregiver of this young boy. Yes, he has a sister, 11 years old, and the father. Okay, the father and the daughter, let's say, are doing more than before because they have to do things that their mother or his spouse was doing before, to let time for the mother to stay with the child and to go to hospital with them. So the family routine is changed, the structure of the family is changed. Okay, that's the first thing. The second thing, as I mentioned, communication is the most important thing. And here I have to go back to Nietzsche, who said that it's not the lack of love, but the lack of friendships in the couple that lead to divorce. If you are not friends in family, you will not end it well. And this cancer disease is a challenge. As we both know, yes, all the relations or the couples are challenging all the time, yes. But if it's the lack of friendships, we can't go further. So the communication between the parents, it's a must. Okay, that's another thing. Then, with regard with the children, there are our recommendations, and she was doing this very well, is, as I mentioned before, honesty and sincerity. We have to go to hospital. Why? Because, okay, the children don't understand the medical term. They just know that they have to go to the hospital. Okay, the daughter of 11 years old, she already started to think, but the boy has only perceptions of going. He doesn't understand why. So you have to be sincere on their level of thinking. With the girl, they explain very clear, we have to go because your brother is here. And her question was, are we gonna be a normal family in the future? Again, it's not an easy question, but we expected this. Because for the first time, she wanted to go with her brother in doing chemo. That means that the parents did a tremendous job because it came from the daughter. Then comes another challenge. This mother has 2 children. The daughter doesn't have to feel that she's not the same importance as her brother. This is not an easy task. Also for us as specialists to learn parents how to do it. Even though you are tired, even though you can't move forward, even though you don't want tomorrow to come, yes, you have to spend time at least 30 minutes alone with the other child, because he or she doesn't have to feel inferior than her brother or sister. So to assure this, let's say, balance between children is not an easy task. and always it comes on the mother. The dad is doing its job as much as he can. Everyone is doing their job because the routine is changed, the structure, everything is changed. Yes, we are not going on holidays, we are going to the hospital. That's the reality. We have to be sincere. That's the life. We have to understand that is a challenge and we are learning them. That this challenge can unite the family more than ever. And then this family that I'm talking about can get out of this stronger than before. And also the outcome will be, let's say, much better than an overall family. So this is about communications. They have daily communications. It's honesty, it's communications, it's friendship. And we don't have to hide through, because if we are not telling to our children, that doesn't mean that they don't know the truth, because they are just looking on the internet. And the risk, it's higher to find out, as I mentioned before, disinformation with, in my case, her brother, than from the parents to tell her. Because she will find the truth about her brother, and then she will feel betrayed by the parents. So even though it's hard, always telling the truth is the best way to deal with any situations. And trying all the time to do this balance between children. This is a must. I hope I answer okay.
Yes, and thank you for sharing that powerful story. And when you were mentioning the outcome, it led me to another topic that I want to speak to you about, which is the post-traumatic growth. Can you explain what that means in the context of cancer, please?
Yes. Post-traumatic growth. I have now to go a little bit again, a little bit. I hope there is time for 1 minute to share the story. As I mentioned at the beginning of the interview, Psycho-Oncology field, domain, whatever you want to call it, it's a new one. Yeah, 4 decades, it's new one. We apply strategies, mechanisms, concepts that were verified in other fields. Yes, I mentioned about coping, you mentioned about coping, but people don't know that coping appeared also in 84, 85 with the famous book of Richard Lazarus and Susan Folkman about coping and appraisal. Why? Because it was, if you remember, or our audience knows better than us, that it was the problem of HIV situation in the United States. And with the story of that legendary basketball player that recognized, okay, so coping was an answer to a psycho-emotional distress for a population. Post-traumatic growth was built for the veterans who were in the army operations. Here I have to do a mention. There are two, let's say, not dynamics, two ways of or two interpretation of post-traumatic growth. It is one more or less, let's say, European by Dr. Linley, more or less not philosophical but more European, and it is the classical one of Dr. Tedeschi and Calhoun. And I'm going to talk about Dr. Tedeschi and Calhoun. So coping from HIV, we are trying even now to apply to cancer patients all the time. Yes, okay. Post-traumatic growth was the same issue for the first time to the cancer patients. Why? Because we have this word trauma. Yes, post-traumatic growth means how can we find good in bad? Yes, how can we find a motivation in a traumatic event? What is traumatic event? It's a traumatic. It is something that affects our cognition on medium and long term. Yes, okay. It's trauma and it's associated traumatic event. For a part of the patient's cancer is trauma, for the other or caregivers, cancer is an associated traumatic event. Okay, there are few studies. This is one of my fields of interest nowadays, and working, let's say, working a lot on this thing. And I had it will appear an editorial and I was writing about if the cancer patients still have time to apply post-traumatic growth, because post-traumatic growth is a process, and we found out that it is time, even though cancer patients don't have time, it is time. And post-traumatic growth to cancer patients is a new notion. There are a few studies, but as time goes by, yes, like in Casablanca, year by year the studies shows that the beneficial of applying post-traumatic growth concepts or domains, which are 5, and I will mention them, lead to better outcome. And it is more important that lead to better outcome to AYA, to adolescents and young adults. Of course, it depends a lot of the cancer type, because we can't talk about post-traumatic growth, for example, to pancreatic cancer patients. For example, yes, because it's a process. And I mentioned the domains, which are very important, and why we are talking about post-traumatic growth also to cancer patients, because post-traumatic growth first means new possibilities. As I mentioned also to the case of the family, new possibilities is the new reality. Cancer creates a new reality. The past reality, you just have to forget it. It's not there. Then it's about deeper relationship. Exactly what I mentioned before. If we are not friends, we can't go further. Cancer is not a disease that you can fight alone. Cancer, it's a disease that you need support. And here I remember the words of the great writer Gogol, the Russian Gogol, who said that you have to surround yourself with people, not with things. Cancer is a disease where you have to be in the middle of people. Things doesn't help you. Yes. The third one, post-traumatic growth means personal strength. Cancer fighting means motivation. We are working a lot of doing and giving daily motivations to cancer patients. We have to find the good in bad. That means personal strength, because life is sinusoidal, as I like to say it. Yes, it's good and it's bad. It's good, it's bad. This is life. It is not only good, it is not only bad. It's sinusoidal. Yes, and we have to find personal strength every time when we are on the descending part. And it's very important to be sinusoidal like this than to be like this with extremes. Yes, and this is post-traumatic growth personal strength means the descending, to be more lightning. Then it's appreciation for life. every cancer patient, the first thing they said is, I wish I could have more time. This is the first thing. Then comes the appreciation for life. Then comes the meaning of life. And here I'm coming to the fifth domain, which is spiritual and existential change. Because spirituality is the first domain where every cancer patient is going in finding his or her God to believe, in which he or she believes. And this existential change is in fact the meaning of life. We have to find a new meaning of life. We don't have time. So what is our meaning of life? And there are 4 characteristics of meaning of life. If you want, I can share with you if you want. If not, I can skip them. It's okay if I share.
Yes, it's completely fine. Please.
The first, I'm not putting now in order, but the first one is the fact that we are living a limited life. Yes, we are born and we are dying. That's a fact. This we can't change. Yes, okay. During our lifetime, we have what is called a legacy. This is another source of meaning of life. Which legacy we left behind? And I ask every cancer patient, which legacy you think you left before the cancer diagnosis, and which legacy you want to left after? Or how do you want to be remembered after your cancer diagnosis? Then it comes the fact that we are connected with the nature. As I mentioned before, appreciation for life. We are not alone in this world. We are interconnected with the nature, with the things that surround us. And the last one is creativity. We can have a fulfilled life only by creativity, by flexibility, by adaptability. And this is our meaning of life. And majority of cancer patients said that I wish I could have time to appreciate the small things in life. So in fact, they are searching for their meaning of life and thinking where my life was. And the majority of them don't want to look back, because for each person in the world, saying thank you, asking for support, and assume your facts are the 3 biggest issues to overcome. It is very difficult to say thank you, as you may know. It is very difficult to ask for support when you need it, but it's extremely difficult to assume a life that you lived before the cancer diagnosis. And here is the key element. Those who have the power, like in post-traumatic growth, the personal strength to face their past before the diagnosis, they will move forward. They will find the appreciation of life. They will find that good in bad. With others, we have a lot to work with. And I hope I answered to post-traumatic growth as good as I could. Of course, it's a
Yes,
long theory, and but in fact, with regards with cancer patients, it's the thing.
yes, completely. And thank you so much for sharing your expertise. And before we close, I want to ask you if you have any last message, either for cancer patients or families or professionals that are listening to us.
Um, wow, that's a tough one. Usually, usually I don't say to patient what to do or not to do. But as a key message is that uh, let's say for specialists, we need the multidisciplinarity team. We need to be led in the medical team to be there, because it is what is called shared decision making process for every cancer patient, which is another story. But we have to be led there also, because we are the emotional component of the patient. The doctors see the medical issues, we see the emotional issues. Maybe the priest will see the spiritual issues, the nurse, and here I have to mention that in all the persons that I mentioned during this interview, the most important healthcare provider for each cancer patient is the nurse, because the nurse is always, but always with them. And from nurses we find out a lot of information, because it's the nurse who is doing the human touch when he's going to chemo or radiotherapy. It's not me, it's not the doctor. So the nurses are the most important healthcare providers for each cancer patient. So this is a key message for, let's say, the specialist. We have to work as a team. For patients, I would say that it is the moment for every one of them to have the power and the force to look back. We don't have to look back with anger. We don't have to look back with sadness. We don't have to look back with being ashamed of us. No. We have to have the power to look back. Because if we don't see the other face, not of us, of what we believed at that time, we can't build a new. It was a great psychologist named Carl Rogers, which was talking about the new me and the actual me. Yes, but the new me can raise if I don't accept the actual me. So if we don't accept our past and what is happening to me now, we can't be the new me. So acceptance in every circle, if we are talking about pain, if we are talking about grief, if you are talking about everything, is the last point. And is the last point with a reason. Because till acceptance are at least 4 or 5 different steps. So when we accept ourselves, we can move forward. And for my colleagues, youngest one, it is a beautiful, really, it is a beautiful field of expertise. It is something where you have a lot of freedom. You have the freedom of choice, the freedom of talking. You have many things, but you have also to have a life experience. It's not like working with disorders where you are, between those lines and you can't go left or right. You just have to follow the road. No, here it's about you. Here it's about handle a question. It's not about giving an answer. It's about handle a question. And it's about learning when to be silent, how to be silent. And for caregivers, which are the same importance as the patients, to be there for the patients, to be there for the loved ones. Because the statistics prove the opposites. In couples, especially in young adults or adolescents couples, when one of the members has cancer, it's almost 70% chances for a breakup, which is huge. We need psychoeducation. we need the entire family to be involved. We need unity. We need creativity. And above all, we need trust from our colleagues and from the patients. And I guess that's what I believe.
Thank you so much for such an insightful message. And thank you for sharing your expertise and compassion with us today. This was a beautiful reminder that healing is not just physical, it is emotional, it is relational, and it is deeply, deeply human. And to everyone that is listening, thank you for joining us, and we will be back soon. Thank you so much, Adrian.
Thank you. Thank you so much also.